Hello guys, welcome you all, and I welcome you all to another video of the video series of securing a distinction in medicine law case. So today we are going to discuss another very important topic which is commonly asked in the medicine law case exam, that is a patient presenting with chronic liver cell disease. So today with me I have Dr. Chamara who is a recently passed out medical graduate. So she will be role playing as a medical student and presenting a typical history of a patient with chronic liver cell disease. And after listening to her summary, I will be asking the common questions that we would be asking in the exam. And once she answers these questions, I will suggest the improvements that she can make to her answer. So with that short note, let's move on to the case. So, Chamara, would you like to tell about your patient?
Mr. Sripala, a 52-year-old carpenter from Dalugama and father of two school-going children, who is a diagnosed patient with cirrhosis for 1 year, presented with progressive edema for 7 days and 1 episode of hematemesis yesterday night. The edema had initially appeared in the abdomen and then his lower limbs have also got involved. In this background, he has had an episode of hematemesis of about 2 to 3 yogurt cups. He was unsure whether there was a melena during this period. He has been a heavy alcohol consumer for 30 years, drinking about half a bottle per day. He is also on treatment for diabetes mellitus and hypertension for 2 years with oral drugs with poor control. After being admitted, he was given several IV and oral medications and the bleeding has stopped. He is planned to be sent for the upper GI endoscopy tomorrow. On examination, there is a bilateral parotid enlargement and loss of axillary hair. There is a pitting edema up to the knee level. The abdomen is distended but non-tender. There is no hepatomegaly but a firm moderate sphenomegaly extending 4 cm from the costal margin is present. There is a shifting and horseshoe dullness but no fluid thrill. The cardio system, respiratory system examination and neurological examination are normal.
Right, so good. So she presented a fairly comprehensive history. So there are a few points that I want to highlight in her story. One thing is now, in the law case, you don't have access to patient's clinical records. So sometimes your patient might not know that the patient is having chronic liver cell disease or cirrhosis. So it is better if you use a term like a patient with long-standing liver problem rather than telling a patient with cirrhosis. And in your history itself, when you are presenting the full history, you can show the examiner that how you have worked out the patient has cirrhosis based on your history and examination, rather than telling directly that the patient has cirrhosis. And the second thing is, now this patient, the immediate reason what brought him to the hospital is a hematemesis. Right? So it is important that you analyze the presenting complaint in little more detail. Right? So he has come with hematemesis. So he is a patient with long-standing liver cell disease. So the possibilities are this could be a varicose bleed, this could be a bleeding from a peptic ulcer, or sometimes this could be a malarial tear after several bouts of vomiting. So this part you need to sort of give more emphasis in your summary and in your own case. And secondly, now he has come with hematemesis. So you have to look into the other symptoms which you have correctly mentioned that he is not quite sure about malaria. And then when a patient presents with a hematemesis, the biggest concern is whether he is hemodynamically compromised. So few symptoms with regard to few symptoms to assess the hemodynamic stability is important. Say for instance, this patient comes with a hematemesis and on admission he was having some dizziness. He was having postural dizziness. He was having palpitations. Or his blood pressure had been low. It will be important because that tells us that patient had been hemodynamically compromised. And then once you analyze the presenting complaint, then you can briefly mention about the background problem, like patient has long-standing body swelling which was gradually getting worse. Likewise, you can mention that. And then in the summary itself, now once you have made your mind, okay, so this is a patient with cirrhosis, we have to look into the risk factors. So as you very correctly mentioned, you mentioned that he is a long-standing diabetic patient, etc. etc. That's important. And also the other risk factors like heavy ethanol consumption. So I'm glad that you mentioned he's a heavy ethanol consumer rather than mentioning he's an alcoholic. And again, it is important in this sort of patient to quantify the amount of alcohol he has been taking. So what you can mention is he has been taking, rather than going by the number of bottles, you can mention the number of units. So he has been taking more than 20 to 30 units of alcohol per day for last 30 years. Would give more sense to the examiner to see, okay, this man's chronic liver cell disease is most likely due to ethanol consumption, right? Okay, so after the summary, the first question that we would generally ask in the exam is, what are the problems that you have identified in this patient?
I have identified several problems in this patient, sir. This patient has hepatitis and also asitis, possibly chronic liver cell disease. And he is a diagnosed patient with hypertension and diabetes mellitus for 2 years. And he is also a chronic alcoholic. And as the patient is the sole breadwinner of the family, he also may be facing financial problems as well.
Very good. I think in your problem list you try to cover all the aspects. But it's a very good approach, it's a very good set of problems. But a small thing that you can improve on your problem list is that you can sort of categorize these problems. Now this man is coming with an acute problem, which is the hematemesis. So just give some description on that, right? Say for instance, his acute medical problem is hematemesis in the background of possible chronic liver cell disease, which I think is most likely a variceal bleed without hemodynamic compromise, something like that. And then secondly, you can go for chronic problems. It is chronic liver cell disease, and then you have identified he has asitis, he has generalized body swelling, etc., etc. So he has chronic liver cell disease with associated other complications. And then thirdly, you have identified a lot of risk factors, which again are chronic medical problems. So he is a diabetic patient for many years with, you can say, whether it's a good glycemic control or poor glycemic control. And then the patient has hypertension with good control, likewise. And then, importantly, similar to the medical problems, this patient is going to live with this disease for long years. So then you have to look into the social aspect. So you have to identify what are the social and financial problems, right? So being the breadwinner of the family, having cirrhosis, coming with this sort of a hospital admission, and so there are a lot of financial implications. So it is important that you sort of stress on this point and identify this as a very important problem in the patient's story. Right. Okay, so we'll move to the next question. So Tamsara, assume now you are the inter-medical officer in the ward, and this patient comes to you with this complaint. He comes with a bout of hematemesis. So as a house officer, how would you manage this patient?
So I will immediately attend to the patient and give a HDU bed. I will assess the airway breathing and circulation quickly, and in the circulation I will insert the patient to a wide bore cannula and take blood for investigations like full blood count, coagulation profile, blood group in and DT, and I will give the patient a crystalloid bolus. As the effective management, I will start the patient on 2 mg of terlipressin followed by 1 mg of terlipressin 6 hours for 72 hours. Then I will give a single vitamin K dose of 10 mg. And then once the blood is available, I will transfuse the patient to replace the blood loss.
Right, so that's a fairly good approach, but there are a few things that I would like you to improve. So this is a medical emergency. As you very correctly mentioned, you will rush to the patient and you will attend the patient immediately. But it is not always necessary to mention that you will give a HTU bed, because HTU bed itself is not therapeutic. But you can manage the patient in the acute side bed and you will attend to the patient immediately. And always in medical emergencies, we talk about airway breathing and circulation. Right, so in this sort of a patient whom we have taken the history, who gives a history, the airway and breathing is fairly alright. So here the emphasis should be given on the circulatory compromise. So as you mentioned very correctly, you have assessed the patient, you have checked the blood pressure and then the peripheral perfusion, and then you will start the patient on a crystalloid. So that's important because patient has probably lost a significant volume of blood with the hematemesis. And then you have to think about the definitive management. So the definitive management would be, if he is bleeding from a varices, to stop the bleeding by either giving sclerotherapy or ligating the varices. But for that, patient needs to be hemodynamically stable. And the other important thing is, even in chronic liver cell disease patients, 30% of hematemesis is due to a non-varicose cause. So it could be a bleeding peptic ulcer. So you generally start managing the patient for both conditions, possible varicose bleed as well as for a non-varicose bleed. So as you mentioned correctly, so you have done the basic bloods, you have taken blood for DT and cross-matching, and you have started the patient on a crystalloid bolus. And as you mentioned, you can consider IV terlipressin because it is sometimes available in the hospital, sometimes it may not. But terlipressin has shown some mortality benefit. So you can give IV terlipressin, and at the same time you can start the patient on intravenous omeprazole, 80 mg bolus followed by a 8 mg per hour infusion. And then the other important thing you have to mention is, now after a varicose bleed, starting the patient on a broad spectrum antibiotic is shown a great mortality benefit. So this patient needs to be started on intravenous ceftriaxone following the varicose bleed. And then when it comes to the transfusions, what we follow here is a very restrictive transfusion strategy. So what simply means is that just because patient is having hematemesis, you are not going to give him pint of blood blindly, right? So your main target is to keep the hemoglobin between 8 to 10, and if you overcorrect or over-transfuse the patient, that might worsen the hematemesis. So you are going for a restrictive transfusion strategy, and then once the patient is hemodynamically stable, then this patient you can liaise with your surgical colleagues and you can arrange an upper GI endoscopy for this patient. Right, so let's assume that we have managed this acute hematemesis very efficiently and the hematemesis has stopped. But what are the measures that you would take to prevent a recurrence of this sort of a presentation, or in simple, recurrence of hematemesis?
So I will start the patient on lifelong beta blockers.
Okay, yes, that's the correct answer, but it is good that if you a little bit emphasize on your answer. Say for instance, there are a lot of beta blockers. So there is evidence for non-selective beta blockers. So your approach should be, you will start the patient on a non-selective beta blocker, and then you have to gradually titrate the dose up until you achieve a 25 reduction of the resting pulse rate. So we have propranolol and sometimes we use carvedilol or metoprolol as well. So you start the beta blocker and you have to monitor the blood pressure, you have to monitor the pulse rate, and then until the blood pressure permits, you can increase the dose of beta blocker until you achieve a 25% reduction of the pulse rate. So that can be used as a secondary prophylaxis. In addition, whenever you diagnose chronic liver cell disease in a patient, you have to refer the patient for an upper GI endoscopy. Sometimes you might find grade 2 or grade 3 varices which are not actively bleeding. So in these patients also, you can go for sclerotherapy or banding as a prophylactic measure. So those are the measures that we will use to prevent the recurrence of hematemesis. Alright, Damsala, now assume this patient comes to you and you find that he has gross abdominal distension and you find free fluid in the abdomen, but there is minimum swelling in the legs. So what are your thoughts? What do you think?
So I would like to consider other causes like heart failure, chronic kidney disease and nephrotic syndrome.
So when you ask this sort of a question, now this is a patient whom you have taken the history, who has cirrhosis, but you find he has abdominal distension with minimal leg swelling. So then what you need to consider is the causes for differential asitis. It is good to think about heart failure, CKD and nephrotic syndrome, but then the patient's presentation would be quite different, right? So in this sort of a thing, what are the causes that can give rise to a differential asitis in a cirrhotic patient? So one such possibility is that cirrhotic patients are anyway at risk of developing hepatocellular carcinoma. So this could be development of a hepatocellular carcinoma where they present with a differential asitis. And also, the cirrhotic patients not only have a bleeding tendency, but they also have a clotting tendency. So then they can have portal vein thrombosis, which can give rise to a differential asitis. And also spontaneous bacterial peritonitis can give rise to differential asitis. And it may not be related to cirrhosis itself, but the cirrhotic patients are having immunosuppression, so they can get all other chronic infections intra-abdominally. Say for instance, peritoneal tuberculosis can present with a differential asitis. And also other intra-abdominal malignancies or peritoneal malignancies can present with differential asitis. So it is important that when we ask such a question in the exam, that you discuss the patient from your patient's context, the particular patient that you have taken history and you have examined. Okay, so now sir, as you know, this patient who has presented with hematemesis is having generalized body swelling as you mentioned in the history. So how would you manage his asitis?
So I will start the patient on 100 milligrams of spinal lactone and 40 milligrams of fusamide, and then I will titrate the dose up to 400 milligrams of spinal lactone and 160 milligrams of fusamide. And if the medical management fails, I will go for therapeutic paracentesis.
Right, so that's a good answer. But the only problem with this answer, the thing that you can improve on this answer is, whenever we talk about management, it is not only pharmacological management. There is a big role of non-pharmacological management in patients with cirrhosis with fluid overload or asitis. So non-pharmacological, there are a lot of things that we can do. So generally when this patient comes to the ward as a house officer, the first thing you need to start is to start him on a daily weight chart. So then you know whether his asitis is responding to your either non-pharmacological or pharmacological treatment. And then one other important thing is that you need to go for a fluid restriction. So if the patient is grossly fluid overloaded, you can restrict the fluid to say 1.5 liters to 2 liters. And depending on the severity of edema, you can further cut down on the fluids. And again, you have to advise the patient on reducing the salt in the diet. And when the patients are very symptomatic with asitis, just a couple of days of bed rest will help the asitis as well. So with this non-pharmacological management, then you will have to go for the pharmacological management. So the basic concept here is that the asitis is mainly due to high aldosterone levels in the blood. So we have learned in your physiology, because of this cirrhosis, there is splanchnic vasodilatation and there is redistribution of the blood, which leads to increased aldosterone secretion from the renin-aldosterone system. So this hyperaldosteronism is the main culprit. So the first line management of asitis is to start the patient on an aldosterone antagonist. So what we have is spironolactone in the hospital setup, but there are some other mineralocorticoid antagonists like eplerenone, which are having lesser side effects compared to spironolactone. So you start the spironolactone and then you can consider starting a loop diuretic like fusamide if the response is poor. So the two drugs, the spironolactone and fusamide, they are synergistic and they sort of complement each other. So as you correctly mentioned, you start the spironolactone and fusamide at a lower dose, so 100 milligrams of spironolactone and 40 of fusamide, and you can go up to 400 milligrams of spironolactone and 160 milligrams of fusamide. So the ratio being 10 to 4, right? Spironolactone to fusamide. And then during this process, you need to closely monitor the patient and you have to see the response to your diuretics. So basically what we expect is, if the patient has peripheral edema, as in your patient, at least 700 to 1000 grams of weight loss per day, and if the patient does not have any edema, in peripheral edema, around 500 grams of weight loss per day. Right, and also the important thing is when you give high doses of spironolactone, the patient can become hyperkalemic, so you need to monitor the serum electrolytes as well. So once you have started appropriate non-pharmacological and pharmacological management, but still the response to diuretics is not adequate and the patient is still having asitis, so in that case, what we call is, it's a treatment refractory asitis. So in that case, there are other measures. Particularly if the patient is really symptomatic, we can consider a therapeutic paracentesis. So we can do a paracentesis and we can remove few liters of acetic fluid to give a symptom control to the patient. But if you are going for a large volume paracentesis and this patient is hypoalbuminemia, so with the paracentesis, patient can become intravascularly volume depleted and patient can become hemodynamically compromised or patient can get an acute kidney injury. So in that context, it is good that you replace the patient with intravenous albumin when you are doing the therapeutic paracentesis. Okay, Namsara. Now assume I'll take you to a different scenario. Assume the same patient comes to you, but this time it's not with hematemesis. But patient complains of a low-grade fever and he's having abdominal pain. So what could you suspect?
Spontaneous bacterial peritonitis.
Yes, that's the correct answer. So spontaneous bacterial peritonitis is something that you have to always suspect, and you should have a low threshold to clinically suspect this condition, because in this patient, of course, he has abdominal pain and fever, so it is very obvious that he is having SBP. But sometimes the cirrhotic patients can have a general decline, they can deteriorate even without fever or abdominal pain, because sometimes they are immunosuppressed that they can't mount an inflammatory response. So always in this sort of a patient, you need to suspect spontaneous bacterial peritonitis. Okay, Damsara. So now we have very correctly suspected the diagnosis of spontaneous bacterial peritonitis in this patient. So how would you confirm your diagnosis and how would you manage this patient?
I will do a diagnostic paracentesis to diagnose the condition, and if it's positive for spontaneous bacterial peritonitis, I will start the patient on IV ceftriaxone 1 gram BD for 5 to 7 days.
Right, so that is the correct answer. But it's good that whenever we ask about how would you investigate a patient or how would you confirm the diagnosis, it is good that you mention exactly what you would do and what samples that you would send and how would you confirm the diagnosis. Say for instance, the ideal answer would be, so if I suspect spontaneous bacterial peritonitis, I would do a diagnostic peritoneal tap in my patient. Right? So, and I will send the samples for gram stain, culture as well as the full report. So in the peritoneal fluid full report, if your WBC count is more than 500 and if your neutrophil count is more than 250, that confirms the diagnosis of spontaneous bacterial peritonitis. And then when it comes to the management, it is good that you mention, because SBP can kill a patient. So you can't wait for your diagnostic peritoneal tap report to come to start on treatment. So you empirically start the patient on a third generation cephalosporin, and then once the confirmation is obtained, you have to continue the cephalosporin. Say for instance, IV ceftriaxone 1 gram twice a day, at least for 5 to 7 days duration. If a patient had one episode of spontaneous bacterial peritonitis, the patient will need lifelong prophylaxis to prevent another episode of spontaneous bacterial peritonitis, what we call as secondary prophylaxis against SBP. So generally what we would prescribe is a drug like a quinolone, like a ciprofloxacin or norfloxacin as prophylaxis. Right, Damsara. So in this particular patient, now we think he has chronic liver cell disease. So what do you think is the most likely cause for his cirrhosis?
So I think it's alcoholic cirrhosis because the patient is a long-term alcoholic.
Yes, I think you have gathered a good history about a significant alcohol consumption in this patient. So we can assume that alcohol may be the most likely reason. But in the same patient, he has a significant history of a poorly controlled diabetes. So then the diabetic related fatty liver disease can again could be a cause for cirrhosis. So you have to weigh this. So what you can tell is, in examination you found he has significant parotid swelling and he has dupuytren's contracture, etc., which are more in favor of heavy ethanol consumption, and then in history has been consuming ethanol for long years. So most probable cause could be alcohol, but I would like to consider the other causes. As he is a diabetic, I would like to consider the possibility of non-alcoholic liver cell disease and also other rare causes as well. So if I just slightly change the history, so this particular patient is a 30-year-old female who does not consume alcohol and she's diagnosed with cirrhosis. What are the other conditions that you would consider?
So I would consider autoimmune hepatitis, primary sclerosing cholangitis, primary biliary cirrhosis, Wilson's disease and hemochromatosis.
Right. Okay, so that's a good list of differential diagnosis. So this is a non-ethanol consuming young female who is diagnosed with chronic liver cell disease. So as you very correctly mentioned, autoimmune conditions like autoimmune hepatitis comes up in the list. And you have thought about other genetic conditions like hemochromatosis and primary biliary cirrhosis, primary sclerosing cholangitis, and hemochromatosis as well. Right. And also in this sort of a patient, it's important to consider the possibility of chronic viral hepatitis as well. Particularly hepatitis B and hepatitis C viral infections can give rise to chronic liver cell disease. So sometimes in the exam, when you come with this differential diagnosis, we tend to ask how you diagnose each condition. Say for instance, if a patient is having autoimmune hepatitis, so how would you approach this patient? How, if you suspect autoimmune hepatitis, what investigations that you would carry out? So then it's good that you have some idea like the autoimmune antibodies that you do, and then the place for liver biopsy in conditions like autoimmune hepatitis. And similarly like hepatitis B or hepatitis C viral infections. So what specific tests to be requested? So as a house officer, your consultant might ask, okay, screen for hepatitis B and hepatitis C. But you should be aware that what to be requested in the blood sample that you are sending to the lab. Say for instance, if it is hepatitis B, you will be asking mainly about hepatitis B surface antigen. And if it is hepatitis C, you will be asking about hepatitis C IgM. And if it is hemochromatosis, you will be doing a ferritin level, you will be doing a transferrin saturation, you will be drawing a family tree to see whether it has been there in the families. And then the definitive diagnosis will be made based on the genetic analysis of a HFE gene mutation. So likewise, know the causes of chronic liver cell disease, and then have a chart where the investigations that you will use to diagnose each cause. Suppose this patient is coming for the first time to you, right? So you suspect the possibility of a chronic liver cell disease. How would you plan your diagnostic workup?
So first I will do the investigations to find the cause, and then to look for the complications I will proceed with PTINR, serum bilirubin, serum albumin, serum electrolytes and serum creatinine.
Right. So that is a fairly okay approach, but I will prefer a slightly different approach. Now this is a patient whom you are suspecting the chronic liver cell disease. So the first set of investigations you should aim at confirming your diagnosis, and then the cirrhosis could be due to many reasons. So you need to look for a cause. And then the thirdly, cirrhosis is associated with a lot of other complications. So investigations to confirm the diagnosis of cirrhosis, investigations to look for a cause, and investigations to look for complications should be your approach. And generally what we commonly see is when we ask, okay, how would you confirm the diagnosis of cirrhosis, you will tell liver functions, AST, ALT, bilirubin, but of course these tests like AST and ALT, the transaminases are not really liver functions. So the answer we expect is when there is chronic liver cell disease, the synthetic functions of the liver will be impacted. So those are the liver functions. So what you can do is you can do a serum albumin level and you can do a PTINR. And then further to confirm it, cirrhosis is basically there is fibrosis of the liver. So the liver becomes coarse, it becomes shrunken, and sometimes it becomes nodular. So doing an ultrasound scan will help the diagnosis, help us making the diagnosis. But the gold standard of diagnosing cirrhosis would be to show that there is fibrous tissue in the liver, which is done by doing a liver biopsy. But doing a liver biopsy to diagnose cirrhosis is with a lot of other consequences, because they have a coagulopathy, they have low platelets, and there are other very reliable means of diagnosing chronic liver cell disease. So we don't generally go for liver biopsy unless there are very ambiguous or very difficult cases. But generally we go by the synthetic functions of the liver followed by an ultrasound scan of the liver, which most of the time confirms the diagnosis of cirrhosis. And secondly, the cause. So in the previous question also I told you there are a lot of causes, so you have to look for each cause. So this cause can be sort of identified from a detailed history, sometimes by the examination or sometimes by the investigations, like the hepatitis virus screening and the ferritin levels, etc. And then the third thing is the complications. So the cirrhosis can be associated with a lot of complications, right? So a lot of complications with regard to portal hypertension. So doing an ultrasound scan, you might be able to see whether there is a splenomegaly, whether there is asitis, or whether there are splenic varices, which will tell the patient is having portal hypertension. And you'll have to do an upper GI endoscopy to see whether there are esophageal or fundal or gastric varices, or whether there is portal gastropathy in the stomach. And then doing a serum creatinine will tell us whether the patient has any amount of renal involvement, right? So in cirrhotic patients, there is a condition called hepatorenal syndrome, which is of course a diagnosis of exclusion, but in such patients, the creatinine will be elevated. So similarly, there are investigations that you would do to look for complications. So whenever you are asked about the investigations, always use this strategy where you use investigations to diagnose, you do investigations to find the cause, and you do investigations to look for complications. Right. Okay then, so now assume that you have very efficiently managed this patient and you discharge the patient. And after 2 weeks, you find the patient being wheeled into the ward. He's in a stretcher and his GCS is 12. So what are the possibilities that you will consider in this patient?
It's most likely to be due to hepatic encephalopathy.
Yes, I agree. So hepatic encephalopathy is one of the serious complications in patients with chronic liver cell disease, and they do present with reduced level of consciousness. But before making a diagnosis of hepatic encephalopathy, there are a lot of other possibilities that you will need to consider. Now, in this sort of a patient where the liver stores are depleted, and he can easily slip into a severe hypoglycemia. So this time the admission may be with a very low blood sugar, right? So it could be hypoglycemia. And these patients are on diuretics and a lot of other drugs, so they can have electrolyte imbalances. So this presentation, the low GCS could be due to hyponatremia. And also, as you mentioned earlier as well, these patients can have coagulopathy. They have low platelets, they have bleeding tendency. So this could be due to intracranial bleed or a subdural hemorrhage. So that is again a possibility. And they are immunosuppressed, so they can get infections. Sometimes this admission with low GCS could be due to some form of an infection. Right? It could be a spontaneous bacterial peritonitis, or could be a UTI, or could be a pneumonia. Right? So therefore, you need to consider all these things, all these possibilities when the patient presents to you, and you exclude one by one, and then maybe you will be able to diagnose the hepatic encephalopathy. So it should not be the first work in diagnosis. Always you need to look at the sugars, look at the electrolytes, look at the neurology, and then hepatic encephalopathy diagnosis should only be made as a diagnosis of exclusion. Right, so assume now we have excluded all the other possibilities. The sugars are fine, sodium is alright, and there is the CT is normal. So you make a diagnosis of hepatic encephalopathy. How would you manage him?
So I will immediately attend to the patient and give a patient HDU bed, and then I will assess the airway, breathing and circulation and make sure they are intact. And then I will, in circulation, I will gain the IV access and take blood for full blood count, CRP and serum electrolytes and PTINR. And also I will do a random blood sugar to exclude hypoglycemia. And then I will start the patient on deputy management with IV metronidazole and L-onitine L-aspartate.
Okay, right. I think that's a good approach. But there's one important thing, right? When you see a patient with hepatic encephalopathy, he has low GCS. So you have to generally manage this patient as a patient who has low GCS. There are a lot of issues with him, right? So his airway breathing circulation may be compromised. He may get bed sores. He can't turn on his own, and his blood and bowel care may be compromised. He may not be able to take orally. So we have to look into all these aspects and manage patient as a whole. So once you attend to the patient's airway and breathing and circulation, then you can start the definitive management of hepatic encephalopathy. So in generally, there are three main aims in managing hepatic encephalopathy. So the pathophysiology of hepatic encephalopathy is mainly to do with high blood ammonia levels. So you have to take measures to reduce the production of ammonia. Your gut is one place where a lot of ammonia is produced and getting absorbed into the system. And then in cirrhotic patients, the ammonia level is high because the urea cycle is malfunctioning. So there are measures that you can take to stimulate the urea cycle. And thirdly, there is blood ammonia levels which can be converted to non-toxic forms of or non-toxic metabolites. So these are the three things that we can do. So when it comes to reducing production of ammonia, as I mentioned, gut is the main source. So what we can do is we can use certain antibiotics to reduce the gut ammonia production. So, for example, we can use metronidazole, which is given as an oral drug, which will reduce the gut microbiota and help or to reduce the ammonia production. At the same time, we can use lactulose. Now, assume that this is your patient and he has low GCS. So, he may not be able to take metronidazole orally or lactulose orally. So, you might have to put an NG tube and you give metronidazole and lactulose. And the lactulose has a lot of benefits. One thing is it increases the bowel motions. So, it will quickly get rid of the ammonia producing bacteria from the colon. And secondly, the lactulose is something the humans can't metabolize, but certainly the bacteria can. So the lactulose will be metabolized into lactic acid, which forms an acidic environment in the gut, and this acidic environment is not healthy for ammonia producing bacteria. And at the same time, when there is acidic environment, ammonia is going to be converted to ammonium according to the Le Chatelier's principle. So ammonium is less absorbable compared to ammonia. So all these measures, having metronidazole and lactulose, will help to reduce the production of gut ammonia as well as reduce the ammonia absorption. And there's another drug that we can use instead of metronidazole, which is called rifaximin. And of course, rifaximin can be used not only for hepatic encephalopathy management, but also in patients where we use antibiotics as secondary prophylaxis for spontaneous bacterial peritonitis. And then when it comes to urea cycle, there are drugs that we can use to stimulate the urea cycle, right? For example, we have zinc, which is an important cofactor for the rate limiting step in the urea cycle, which is by the ornithine transcarbamylase. So giving zinc supplementation will stimulate the urea cycle. And also there are drugs that we can use to convert ammonia into the non-toxic metabolites. So we have drugs like LOLA. There are two amino acid derivatives, L-ornithine and L-aspartate, which can bind ammonia and form into non-toxic forms. And also benzoate is a drug that we can use, which again binds ammonia and forms into a metabolite called hepurate, which is water soluble and which is excreted in the kidneys. So we can use all these measures in patients with hepatic encephalopathy. And also, sometimes in severe forms of hepatic encephalopathy, patient can develop cerebral edema. So in that case, we can use hypertonic saline as a treatment measure. So assume now this patient recovers from the current admission as well. So he goes home after recovering from hepatic encephalopathy, but maybe after a few months, this patient comes back to you. But this time the complaint is he has severe loss of weight, loss of appetite, and he has a differential asitis. So what would you consider in this instance?
So it could be due to development of hepatocellular carcinoma in the background of having cirrhosis.
Very correct, because cirrhosis itself is a risk factor for developing hepatocellular carcinoma. Right, Chamara. So if you suspect hepatocellular carcinoma, how would you confirm your diagnosis?
So I will arrange a triple phase CT of the abdomen, which is the gold standard to detect hepatocellular carcinoma.
Okay, so assume this patient comes to you and asks, Doctor, can my condition be cured? Is there any definitive treatment that you can offer to me? So what would be your answer?
Yes, sir. The only definitive management is liver transplantation.
So how do you assess the patient prior to liver transplantation? Do you know any scores that we use to see their suitability or the urgency that the patient needs the liver transplantation?
So I would like to use the scoring system CHILD-2.
CHILD-2 scoring system is a scoring system that we do use in cirrhotic patients, but that is mainly to predict the mortality of the patient, right? But in this sort of, in liver transplant, in cirrhotic patients whom we are thinking of going for a liver transplantation, there is another score that we use, which is called a MELD score, right? So usually we might not ask in detail about the MELD score, but it is good to know these two scoring systems that we use in cirrhotic patients. So today's discussion, I think we covered a fair amount of theory and common clinical problems that we encounter in patients with chronic liver cell disease. So if you like this video on chronic liver cell disease, please do subscribe. And in my YouTube channel, there are other videos which are on other common law cases in medicine exam. And hope to see you once again with another interesting law case in near future. Thank you.